We'll make this work. So thank you all for having me here today to talk about hospitalization as an opportunity to offer alcohol use disorder services. My hope is that by the end of the talk, you will be able to describe the current state of alcohol use disorder in the U.S., to recognize, diagnose, and treat hospitalized people with alcohol use disorder, and to identify opportunities to provide services for hospitalized people with OUD. Next slide. I will be reviewing the background on alcohol use disorder in the U.S., including the epidemiology, how it has been affected by COVID-19, and how it's affected our emergency departments. And then we'll switch to focusing on hospitalized people with alcohol use disorder and end with opportunities to intervene and different models of care. Next slide. So I like to start off with this picture, and I think it's because, you know, no matter what department you work in and what your role is, the last time that you were on service, you probably all cared for somebody with alcohol use disorder because of alcohol's many acute and chronic effects on the body. And next slide. And part of the reason is that the prevalence of alcohol use disorder in our country is very high. So among the more than 20 million individuals with an alcohol or drug use disorder, you click Maggie, it'll bring a red box, accounts for about 2/3 of the substance use disorders in the United States. Next slide. And I want to further contextualize alcohol amidst our country's really the national narrative that's very opioid centric. You know, and I think of opioid overdose deaths as the tip of the iceberg for a wide spectrum of substance use in our country. And people have different ways that they use, right? Everywhere from risky use up to severe use disorder. And I put alcohol in red because that's what we're going to be focusing on today. But also because, you know, some people use opioids, but many people don't. They use other substances, they use substances in combination. And then if we click again, we see that there's all these things that pop up in yellow, and these are things that are tied to substance use or sometimes drivers of use, and really thinking about how we can begin to intervene in the hospital to connect people to long-term care to begin to address somebody's substance use disorder. Next slide. So the reality is that in our country, we have a alcohol use disorder crisis in addition to our crisis of opioid overdose deaths. After tobacco, alcohol is actually the leading cause of preventable death in the United States, with more than 95,000 deaths every year from alcohol. This is also concerning, if you click again, Maggie, because the prevalence of unhealthy alcohol use disorder, and alcohol-related deaths is rising. And next slide. And as we can see from this triangle, I want to take a step back before we focus a little bit more on what the prevalence of increasing unhealthy alcohol use and use disorder is, and focus a little bit on the terminology of alcohol use so that we're all on the same page. So at the base of the triangle, you have people who are not drinking, and you also have decreased consequences from use because there's less alcohol use. And as you make your way up the triangle, you have more heavy consumption of alcohol use and more consequences of alcohol use. And so if you click, the base of the triangle is abstinence, so it's people who are not using. And then as we click again, it's people who have low risk alcohol use, and it means they're using in amounts that are considered within safe drinking limits. And then if we click again, we have this blue triangle. And in the blue outline triangle is the whole spectrum of unhealthy alcohol use. And so not everyone with unhealthy alcohol use has an alcohol use disorder. The spectrum of unhealthy alcohol use includes risky alcohol use and mild, moderate, and severe alcohol use disorder. So clicking again and looking at the light blue in the triangle, this is where we have risky use. It's people who are drinking above recommended limits, who don't yet have consequences from their alcohol use, but are at risk for consequences in the long term. People who are in this category of risky use, it's where the best evidence is for a brief intervention, where counseling someone on their risky use can help them move down the triangle into the low risk use category. And then people who are having consequences of their alcohol use, including psychological consequences, comorbidities, relationship trouble, the C's and the R's as part of our DSM criteria have an alcohol use disorder. Then we're going to go on to the next slide. And on this slide, what you can see is that there have been increasing rates of alcohol use from 2001 and 2002 compared to 2012 and 2013. And what we see is that this prevalence is increasing across alcohol use itself, risky drinking, and then also for alcohol use disorder. And if you could look at the percent change in these years, the highest percent change is actually in the category of alcohol use disorder, with an almost 50% increase that is most pronounced in women, individuals with low SES status, and older adults. The next slide. We also see increasing alcohol-related deaths in addition to this increasing prevalence of unhealthy alcohol use. And again, just like the increasing prevalence of use, we see increasing deaths across a wide spectrum, across gender, across race and ethnicities, and socio-demographic characteristics. But the deaths have been especially pronounced and escalating more quickly among women and younger age groups this time. Next slide. So we have this spectrum of pre-COVID alcohol use where people are having increased alcohol use disorder, and we have an escalating number of individuals who are dying from alcohol use related causes. And then comes COVID, and for all individuals with substance use disorder, as I'm sure you're also seeing, COVID-19 has really magnified the drivers of use. It's, you know, when we think back to that iceberg that we showed at the beginning, you think of the psychosocial and economic impacts of COVID, so it's magnifying those drivers, and then all of the isolation. It means that people who, you know, might have been in recovery may return to use, that they may have more riskier use, or that there's new use happening. And we see this corroborated in the media. This headline, if you click, says why America is running out of aluminum cans. And this was at the beginning of the pandemic, and it was because people were ordering, you know, they weren't going out to drink, so they were drinking at home, and they were ordering more alcohol. And there was actually a 54% increase in alcohol sales at the beginning of the pandemic. But, you know, it's not just in the alcohol sales. We also saw this play out in studies. The next headline from a JAMA Open study says changes in adult alcohol use and consequences during the COVID-19 pandemic in the United States. What we saw is that across the board, there was a 14% increase in alcohol use across the country. And again, what was most concerning here is that the impact was greatest in the category of unhealthy alcohol use, so that spectrum of risky use and alcohol use disorder for women, with a more than 40% increase in unhealthy alcohol use. So then, given this national landscape of alcohol use and COVID, we also see that our emergency departments have been affected by this increasing alcohol use during the time of COVID. What this diagram shows is that emergency department visits related to alcohol use have increased across rural, suburban, and urban hospitals pre-pandemic to during the pandemic. And then if we click onto the next slide, we see that for all substance use related emergency department visits from January to August 2020, almost half of visits that are substance related to our emergency departments are related to alcohol. You know, we saw that here at San Francisco General, where I work, and I wonder if this is also something that you are seeing at your hospital. So now that we have this background on the spectrum of alcohol use and the epidemiology and people affected, we are going to take a deeper dive into what it looks like for hospitalized patients with alcohol use disorder. So this diagram shows the percentage, cost, and length of stay for primary mental and substance use disorder diagnoses. And what you have in the x-axis is the mean cost per stay, and the y-axis is the mean length of stay. And what you can see if we click again is that alcohol comprises almost 1/5 of the primary mental and substance use disorder diagnoses. It also has, among all of the substances, the highest mean cost per stay and the highest mean length of stay, which is on par with a hospitalization for community-acquired pneumonia. Then on this next slide, we see the percentage of hospitalizations across in a nationally represented study of hospitals across the United States that involve an alcohol use disorder diagnosis. And this study is unpublished currently, but I hope it will be published soon. And it's by one of our UCSF research fellows, Dr. Leslie Soon, who found that, prior to this study that she'd done, most of the nationally representative studies that use ICD-9 and 10 codes for alcohol use disorder had found rates of about 2 to 3% among hospitalizations. And what she found in this study is that about 6% of hospitalizations involve an alcohol use disorder diagnosis. And, it may be even higher, as you see from this next slide, where this chart comes from an urban academic safety net hospital where they did an observational cohort study and looked at the prevalence of substance use among hospitalized individuals at this hospital. And what they found, if you click again, is that about 10% of individuals who were hospitalized here had an alcohol use disorder diagnosis. And the features that were associated with individuals having an alcohol use disorder diagnosis, as opposed to those who had no substance use, were that they were more likely to be male, be unemployed, experiencing homelessness, not have a primary care provider at enrollment, and have depression. So again, thinking back to that iceberg and some of the drivers of use. And then they also found that individuals with an alcohol or substance use disorder had higher acute care utilization rates. And so to put this all together, when we're thinking about alcohol use disorder among hospitalized patients, it's really about 1 in 10 individuals that we know of that is hospitalized with and has an alcohol use disorder diagnosis. And some studies show that it's about 1 in 3 individuals in the ICU. We also know that alcohol use disorder often co-occurs with mental health diagnoses, and that people with alcohol use disorders who come to our emergency departments are more likely to be admitted. They then have longer lengths of stay, costlier hospitalizations, and higher readmission and self-discharge rates. They're also more likely to have a public payer and be in the lowest quartile of income, as well as be unconnected to care and have low follow-up rates after discharge. So now that we have provided some of the background on alcohol use disorder among hospitalized patients, I would love some of your participation. And if you could type into the chat, what are some reasons that you think we might want to address alcohol use disorder during hospitalization? Now let's see if I can find the chat. I did find the chat on here. Captive audience, I'm seeing. Yes, studies show that, even though people aren't coming into the hospital seeking care for their substance use disorder, right? They are there for, another reason. Maybe they have AFib from their drinking. Maybe they're having a bleed. Maybe they're having alcohol withdrawal. 2/3 of individuals are actually interested in cutting back or stopping to prevent withdrawal, definitely. So we must treat to prevent withdrawal, and alcohol withdrawal can be a deadly disease when it's unaddressed. Yes, Kristen, I see here you said you can talk to a patient multiple times in short proximity, so you have an opportunity to provide motivational interviewing and build on a patient's goals. Yes, Judy, they're more motivated to stop if they experience a complication. As you're going to see from my next slide, these so-called trigger events are make people think about their morbidity and mortality, and perhaps make a change in their life. Dose meds for withdrawal in a controlled manner. Yes, definitely for alcohol withdrawal, and we really see this with opioid withdrawal, where you can get people on really good doses of medication. I see lots of I think this point about people not having primary care providers. We just reviewed that people with alcohol use disorders have low engagement after discharge, and so the hospital may be the only point they're accessing care, and so it really is an opportunity to offer pivotal treatment. And a moment for harm reduction. I love that. It's true. We think of harm reduction so much for people who ingest drugs, right? But harm reduction is for everything. And we have these harm reduction kits we hand out. And we have one for alcohol too here, where it really is just like, a reminder for ourselves to like talk to people about alcohol harm reduction, and includes drinking water in between drinks, making sure that people eat before they drink, etc. These are all wonderful. Thank you so much for your participation. And Maggie, if we can click through the different reasons here, I think you named most of them actually. And I'm going to move on to the next slide, that is facilitators of change after alcohol use disorder associated ICU admission. And this was a qualitative study that looked at individuals who survived an ICU admission related to alcohol use, and they looked at the facilitators and the barriers to change. And what they found as facilitators is really interesting, I think. So one was empathy of the inpatient healthcare environment. And, this comes up actually in other studies where basically I think of empathy as the opposite of stigma. And in qualitative studies that have looked at why people with substance use disorder self-discharge, we know that stigma is a huge reason why they self-discharge. And so, really meeting people where they are and focusing on what their goals are can go a huge way. The other facilitators included recognition of accumulating problems. And so for me, I think of this as, or what they thought of this as in the study is individuals being able to identify the hospitalization, for example, as being related to their alcohol use, and some of the problems in their life as related to their alcohol use. The other facilitator that we talked about was recognizing, having a trigger event, so landing in the hospital, in the ICU, spiritual beliefs, and then the other facilitator was somebody's social network and connections, like encouraging them, supporting them in their goals. And while this was a facilitator, it was also a barrier, because if somebody's social network encouraged drinking, then it would be harder for those individuals to stop. The other barriers included people being pre-contemplative, and this was people who weren't connecting some of the consequences they were having from their drinking, including hospitalization not related to their drinking. And then one big barrier was psychiatric comorbidity, which is really, for me, just makes me think about what I can do differently for my patients. We know so many of my patients tell me that they drink because they have anxiety or depression. And it's really hard to get people into treatment, into mental health treatment. And so thinking about what we can do to address both the mental health comorbidities and the alcohol use disorder to try to remove some of those barriers. And then another barrier was cognitive dysfunction, which also goes hand in hand with some of the long-term consequences of alcohol use disorder. And so really thinking about how, that person who's in the emergency department who's not getting admitted but is there with alcohol intoxication, what can we do for that individual to address their alcohol use early on, even if it's harm reduction, and it's, making sure they have a meal so that they don't have thiamine deficiency and develop Wernicke's at some point, so that they don't go on to develop a cognitive dysfunction, which will then make it harder to facilitate any change in their alcohol use goals. Now we are going to go a little bit and focus on different models of care and opportunities to address alcohol use disorder in the hospital. And I broke these down by, there's a lot of different ways that we can address this, but I broke this down into screening, assessing, and diagnosing alcohol use disorder, treating alcohol use disorder, and implementing a care model. And so on the next slide, you see screening, assessing, and diagnosing. And if you click, you see the first, you see the blue box with all the different screening tests. There's just so many of them. I bolded my two favorites. The first one, if you click, is the single question alcohol screener. And I like this one because it's one question and it's 82% sensitive and 79% specific for unhealthy alcohol use. It doesn't mean somebody has an alcohol use disorder, but it's that first, that blue top half of the triangle where they may have risky drinking or an alcohol use disorder. So you still need to assess them further. The other one that I like, if you click again, is the Audit C, which is 3 questions, and it's the Alcohol Use Disorder Identification Test, -C. The C is for consumption, so it asks about amounts of alcohol that people use. And the reason I like this one is because it gives you a score, and that score can be correlated with having a potential moderate to severe alcohol use disorder. And then if we click again, we see really that, you know, the gold standard for diagnosis of an alcohol use disorder, just like for an opioid use disorder, is the DSM-5 criteria. So that's how we can go about diagnosing it. And that is an opportunity that we have, whether we're in the emergency room, the outpatient setting, in the hospital. Some of you may be wondering, screening in the hospital, that sounds controversial. I thought it was for outpatient. And yes, you're right. The USPS task force recommends screening for unhealthy alcohol use in primary care settings, and it's a grade B recommendation. But you know, I think if we think again, when they've done studies to ask people, it's only about 1 in 6 individuals who reports discussing alcohol use with their doctor. So if we click again, I think we have an opportunity to offer people screening in the hospital, especially if they're not accessing outpatient care. And this has been tried at different healthcare systems, including at an academic hospital on the East Coast, where they implemented the AUD-C that we just talked about as the screening test. And about 60% of the individuals who were admitted to this hospital received the AUD-C. It was performed by a nurse here. 1 in 10 of the individuals who got screened had scores on the AUD-C that were consistent with a moderate to high risk for alcohol use disorder. And so the screening allowed identification and then an assessment and the team to offer more services to those individuals who met criteria for alcohol use disorder. And when we talk about treatment, as we see on the next slide, there's multiple options for treatment. And really any door is the right door, just like it is for opioid use disorder. We have psychosocial treatment and or medication treatment. And people have asked me before, you know, isn't it, you know, don't you need, if you start medication treatment, don't you also need psychosocial treatment? I know that, you know, I work at San Francisco General, but I'm a UCSF faculty, and at our sister hospital, Parnassus, many times when we have individuals who have alcohol-induced hepatitis and alcohol use disorder, many times, you know, people are forced into treatment. They're required to go to AA for 6 months. And, you know, AA is not the only program. There's a lot of different programs that work for people. Some want residential. Some don't want any residential treatment or psychosocial treatment. What they want is medication treatment. And so I just like to remind myself that treatment is treatment, and that less than 8% of individuals with alcohol use disorder are offered treatment. So we can do better, whether it's on the medication side or on the psychosocial treatment side. And if we go to the next slide, you can see my favorite first-line medications for alcohol use disorder. Maybe you can see 2 of them, because I sort of grayed out one of them, and I'll share with you why. These 3 are naltrexone. Also, there's an injectable version called extended release naltrexone. There's acamprosate, and there's disulfiram. These are the 3 FDA-approved medications for alcohol use disorder. Naltrexone is my go-to whenever people qualify for it. It's dosed daily, and it really works on that reward pathway of alcohol, where, you know, by blocking the mu receptor, less dopamine gets released. So people, if they drink and less dopamine gets released, they basically unlearn to drink. So it blocks those pleasurable effects. People ask me all the time if they need a waiver or anything to prescribe it. So you don't need anything. There's no X waiver for anything other than buprenorphine. And it's really easy to start in any setting, as long as people are not on opioids, or it's not contraindicated for another reason, such as decompensated cirrhosis. The number needed to treat to prevent return to heavy drinking is 12, and to maintain abstinence, the number needed to treat is 20. It is great for people who have a lot of cravings for alcohol use. And sometimes if 50 helps people, but not enough, I sometimes, you know, consider going up to 100. And then the second medication that I use is acamprosate. And, you know, this one helps with some of the dysphoria, some of those negative effects that people feel after they stop drinking. It modulates glutamate hyperactivity. You know, it has the best evidence for it is in is in stopping drinking altogether. So you're supposed to start it once you already stopped drinking. It's not useful in reducing drinking. The number needed to treat is 9 to 12 to prevent return to any drinking. One of the things that I don't like about it is that it's 2 pills 3 times a day. So it is, that's fairly a pretty big pill burden. Not everyone wants that. I use acamprosate usually when somebody doesn't qualify for naltrexone. And then there's disulfiram. And the main reason I, stay away from it is that it's really only effective in directly observed therapy. So if somebody has an OUD and is going to methadone clinic, for example, and they're getting directly observed therapy there, and they want disulfiram, I will try it. But otherwise, I stay away from it. And people confuse. A lot of my patients are afraid to try any medication for alcohol use disorder because they think it's disulfiram, they think it's going to make them sick. And that's the nice thing about naltrexone or acamprosate, that even if people drink, they're not going to get sick. And then the next slide, you see second line alcohol use disorder medications. And I won't go through these, but the main point that I wanted to make here is that I use these when first-line medications are not working, or as adjuncts to first-line medications is when I'll turn to gabapentin and topiramate. And on the next slide, I like to, is another way that this is really actually how I really think about alcohol use disorder medications when I'm thinking about my patients. It's really patient-centered. It's what is my patient's goal? Is it to stop drinking, or is it to decrease use? And so if it's to stop drinking, my go-to is always naltrexone if they qualify, or extended release naltrexone. We actually start that in the hospital or emergency department here. And then we also have acamprosate or gabapentin. And then if their goal is to decrease use, again, my first line is naltrexone, but then we also have gabapentin or topiramate. And then you see a few medications in blue. And these have, the data is really mixed for these. And so they're never my first line or second line. They're sort of my last line. And baclofen is crossed out because I used to use it sometimes, but really the data was really mixed for it. And then a recent cohort analysis actually found that there was a dose-dependent increase in hospitalizations and deaths related to baclofen. So I no longer use it in my practice. And I wanted to make sure on this slide that I touched on what we do at San Francisco General for individuals with substance use disorders. So this is our team now, but we just started 2 years ago. And when we started, we had a half-time attending and only one patient navigator. And in the middle is our director of public health, who recently visited our team. And there's a lot of collaborators, so that's why it's huge. Lots of different people here, and an addiction medicine fellow, and a couple of patient navigators. I'm going to focus on that. But before I focus on our team, our consult team, I wanted to just touch a little bit on what we did before we had a consult service in terms of serving people in the hospital. So before we had a consult service, we had 3 licensed vocational nurses who were led by a CNS, who is my mentor. His name is Joe Clement. And every patient who was admitted to our hospital got screened for any smoking, and they received a single question screener. And this was from 2016 to 2018. And I'm going to focus mostly on alcohol as an example of what they did. So over a 2-year period, 17,700 people were eligible for this intervention. And it was admitting nurses who administered the single question screener. The LVN then saw any patient who screened positive for smoking or for unhealthy alcohol use, and then they performed the audit. If the audit was concerning for alcohol use disorder, then the LVNs would assess the patient's interest in naltrexone and their candidacy, and they would communicate with the primary team. It was the primary team's job to then prescribe the naltrexone if they agreed that the patient was a candidate, et cetera. So over this 2-year period, 7,800 people did not get the alcohol use screener, 7,000 screened negative, and then 2,700 had a positive alcohol screener. This is about 27% of those who were screened. Then at the very bottom here, you see that out of the people who got the audit, 520 had risky alcohol use, and then 1,600 had an alcohol use disorder. about 16% who were offered naltrexone. And then now that we have the consult service, we have a few different providers who are involved in providing care. This includes an attending who's here full time now, and we're about to we hired an NP, and hopefully they'll start next month. We have a couple of addiction medicine fellows run through the addiction medicine fellowship here, led by Dr. Paula Lam. We have currently 2 licensed vocational nurses, and we're hiring a third. There's an evaluation team who's helping evaluate our impact so that we can hopefully get sustainable funding. And then we have 4 patient navigators now, including one who is in the emergency department and splits her time between our outpatient substance use clinic, the Bridge Clinic, and the emergency department. So it's really nice to have that handoff. And there's another full-time patient navigator in the emergency department. And then if we go to the next slide, you know, we have about 10 minutes left, and I want to make sure there is time for questions. So if we just scroll to this, there's basically 2 ways that the addiction care team gets involved. And one thing that's a little bit different about our services compared to other consult services is, one, we do have navigators in the ED, and then soon we'll have a provider. We'll provide full consults in the emergency room and psychiatric emergency services. But we also focus on people who have sort of risky substance use before they have a substance use disorder through our LVN effort, where everyone who comes to the hospital gets screened. And then we also have this higher level intervention, and we, with the physician, nurse practitioner, patient navigators, and we all sit in one room, and we're one big team and work together. So sometimes, you know, I'm on service right now, and the LVNs will refer patients who who have more complex substance use disorders, or they have an interest in psychosocial treatments. Last year, we discharged more than 60 people straight to residential from the emergency department or hospital. And then we also worked as a traditional consult service where people place a consult, and then we will see them. And on the next slide, you see this is an example of the workflow that our licensed vocational nurses have for naltrexone and acamprosate, all the other alcohol use disorder meds, and who qualifies for it. I just wanted to show a little bit of what our patients, you know, look like and who's consulting us. On this slide, you see that half of our consults come from internal medicine, but over time that is changing with like the other box and the trauma box compromising a bigger amount. And so we're really working hard to increase the number of consults from our surgical services. And then in terms of the substances that we're consulted for, it's variable, right? It's about a third opioids, a third alcohol, and a third stimulants, with many people having more than 2 substance use disorders. The primary diagnoses that people have when they're admitted also tend to be related to their substance use. And on the next slide, you can see a little bit of our who our patient population is at the county hospital. Half of the individuals have a mental health diagnosis. Half are Black or Latinx, unconnected to care, don't have a phone, or are experiencing homelessness. But almost every single patient that we see wants some kind of help. So as we finish up this presentation, you know, just thinking about no matter what your role is on the team and where you work, we all have an opportunity to offer some kind of alcohol use disorder intervention, whether it's screening, assessing, and diagnosing, treating the alcohol use disorder, or working to implement a care model. And I will take questions.
Thank you, Marlene. That was fantastic. I think a lot of comments in the chat that you can take a look at as well, but I'm just going to pick out a couple of them. Tara Tawil, who's an internist at LG, said, have you seen any differences in success with extended release naltrexone or oral? Do you have a preference to start one or the other?
Yes, our protocol includes starting an oral dose, especially in people who haven't tried it before, to make sure they tolerate it. So we'll start 25, and if that works, then we will offer the injectable if that's what people want, and they express, you know, pill burden is an issue. I can't remember. I start drinking and I stop my pills. It took a lot for us to get this medication on formulary because the hospital has to cover the first dose of the medication, and it's $1,000 on the inpatient side. And so they were pretty strict with us at the beginning, and now we have a little bit more leeway. But whenever people want the injectable, we give it to them because we find that since we started giving it in the hospital, it's way more likely they'll follow up for the second dose. Before, when we used to refer them to our clinic to implement the injectable, it was unlikely they would show up for it. I think the other thing that we've done is like we work really closely with our outpatient providers to ensure that the clinics all have the injectable naltrexone, and so not all of them do right now. And so the Bridge Clinic here is really nice. That's run by my colleague, Dr. Hannah Snyder, and it's open 3 half days a week, and people sometimes go there for their injectable naltrexone.
That's great. Diane and I were on a call this morning, and I locally, and I don't know if Kyle Campman's still on. My understanding is the drug company will actually pay for the first injection of naltrexone in the hospital or in the emergency department. I don't know if Kyle wants to unmute and comment, but I know that Kyle is actually using the IM naltrexone in patients getting admitted to his substance use service at the VA. Kyle, are you still with us? So he's a addiction psychiatrist who's been really an expert at addiction care, has taught all of us a lot. But many of my other colleagues, even in this area, I heard about on this call that at Cooper, they're actually giving injections in the emergency department or on the consult service in the hospital, and that Alkermes is paying for that, just providing it and providing up to 3 months of free care. So I'm not sure if that's something that you can.
The issue is that our hospital won't. They do offer it to us here too, but we can't take the medication from the company, and so we have to pay out of pocket, unfortunately. But it's okay. Most of our patients, 70% of our patient population is on Medicaid, and so we pay for the first dose. But then in the outpatient setting, it's covered in the FQHCs by Medicaid, so that makes it really nice for follow-up. And even for people who don't have, who may be undocumented and don't qualify for Medicaid, we work with the Healthy San Francisco to ensure that the medication is covered, at least for a year, so that we don't run into some of the equity issues, because a lot of our patients with alcohol use disorder also happen to be Latinx.
Great. And Ronnie Nandwada asked, is there evidence for using naltrexone and acamprosate together?
They did I think they studied it in the combined trial, and what they found is that there was no greater benefit by adding both, right? And so my practice is if a patient has already, if they feel a little bit of benefit from each, like why not try it together, especially if, alcohol use disorder is playing a big role in their lives. I personally probably use naltrexone plus gabapentin more often, and that's because I will often do gabapentin to try to spare some benzos for alcohol withdrawal in the hospital, and then there's some data for gabapentin in alcohol use disorder. So that's when I'll end up doing naltrexone plus gabapentin. But I am probably going to see a consult this afternoon the patient is already on acamprosate, and I'm gonna go chat with her and find out. It sounds like we were consulted to see if we should add on naltrexone. So I will see what happens here.
Great. And there's some questions about volume, like an estimate of ED patients who might want this. It's asked about if the ED providers administer naltrexone without consulting your team. And Ronnie asked, how many consults do you get in a normal week?
Yes, all these are great questions. So we get about, I would say, like 90 consults for inpatient a month, and then our navigator in the ED sees about 20 to 25 patients a week, I would say. The prescriber is not in the ED yet. Hopefully they will be by April, where we will open up for full consults. The emergency room has had a slower uptake of extended release naltrexone, and partly is because there's so many issues with our flow we're always on divert, and we try to keep up flow, and so that has been a little bit of an issue. We've started some oral naltrexone. A lot of the efforts in the ED started, whereas inpatient, it all started with alcohol. In the ED, it all started with buprenorphine for OUD, and so we're slowly sort of changing culture and really helping address all substance use disorders. I think it'll help once we have, in addition to the navigator, the prescriber. I think the other part with all of these medications is that they're a pill, and there's reasons. If you go back to that, the iceberg, why people are, using their chosen substances. And for OUD and AUD, I think for OUD especially, the meds are great, and for AUD they're pretty good. Then for other substance use disorders, they're less good. And it really is about that engagement in care, and hopefully the medication helps people be able to engage in care, but really decreasing the red tape that people have after discharge to accessing treatment. And that's why the navigators, I think, are so important, because they give the patients a card. If the patients have trouble, they can call the navigators. Because giving an injection is great, but then how are they going to get more of it, and how do you coordinate the care? And so I think of our team almost as the palliative care service, where we come with like different things. And I think the harm reduction kits have also been a great intervention, because I think our patients really feel that we are truly not being pushy, and we're meeting them where they are. And we just had a lot of, we had, I think, about 10 admissions in the last week, where there was a big batch of stimulants that were contaminated with fentanyl, and there were a bunch of ICU admissions related to that. And so right now, the ICU attendings just found out that we had fentanyl test strips, so we're getting consulted a lot to provide some of the harm reduction kits.
That's great. And speaking of harm reduction, I think Judy wanted to know what was in your harm reduction kits, or maybe Ronnie, for alcohol.
So it depends. For alcohol, it's a lot of the resources in the community. It's education on, like, really eating before you drink, some of the groups in the community. And then we have specific ones. So if somebody is injecting stimulants, if somebody is injecting fentanyl, if somebody is smoking fentanyl, so we'll cater them to how the patient is using and what they're using. We have the kits pre-made, a couple of different kits pre-made, and then we fit them to what the patient wants. And we worked really hard with leadership to make sure this was okay, and we partnered with a local community-based organization who provides us all the supplies, which is awesome, so we don't have to run into all the policy issues around this, or federal funding or anything like that. And also, like, we really want to make sure that people are connected to harm reduction experts in the community. And San Francisco, we're lucky in that there's so many wonderful groups leading these efforts. And so we provide a lot of information of where to get more kits, but many of our patients are already connected. It's really just making sure that people who have this urge to use after they leave have access to needles and everything else they need, to prevent the harms of use. I think the other thing that I just, wanted to stress, that even before we had a consult service, our LVNs were doing so much, and that it really is a big team effort. We help each other. I think the doctor part of this is like, more of our consults are for navigators and our LVNs than for the doctors. And that's just, and we learn from each other around all this work.
Yeah, I can't echo enough the multidisciplinary model and the care navigation that our peers provide has really been essentially, in a lot of ways, we have been doing something similar to this in the past couple of years, where the peers are meeting our patients and, identifying where we can be helpful if we even needed to be involved. Much of it was really, at the level of care navigation, which it's, it is a tribute to their work, but a sadness for the complexity of healthcare for any diagnosis in this country. Crazy. Rachel McFadden actually also was highlighting that, in a single patient engagement regarding a short stay, like an observation unit or ED, can you accomplish that? Like, do you consult in the ED or OBS unit, or were you saying that they're less interested because of ED flow issues?
So we haven't had the bandwidth to go to the emergency room other than the navigator. We've had a navigator, Mitch, who's awesome. They've been there since March of 2020. And then we got some other patchwork funding for a second navigator who splits her time with our Bridge clinic. So she's there 3 half days. And so that's been good. And I think also, the ED is a really hard place to work for all of our providers and our nurses, and especially at all our hospitals, right? And so I think just acknowledging the trauma that both patients and providers have had there, and it's going to take time to make some of that culture change happen. And the navigators are wonderful, and there's still so much that we can do. And I hope that by having more presence there with like the whole team, that we can help address some of that. And and also feedback some of the stories of the people who do well, because you don't hear that in the emergency room, right? And we hear some of that on inpatient, but it's really the outpatient who gets that benefit. And so trying to like do more of that and provide people, open up a conversation. I think that's where the harm reduction kits in the inpatient side has been really good. It was a huge partnership with nursing also. They are the ones who like allowed us to make it happen. And every time we provide a harm reduction kit, we also meet with nursing before we provide the kit, so we're all on the same page and there's no accusations around, people using or something like that, because this is actually how the effort grew out. There's a patient who delivered and they found the overnight team found supplies from substance use that were in her belongings and like called, police to get involved. And so like that was just so unfortunate. We really are trying to do lots of education. It helped change our hospital's drug and substance use policy, like possession policy, all this stuff. So a lot of good has come out of this, but it took a very unfortunate thing to make it happen.
Yeah, no, that's great. That's another really important hot topic and a great area for partnership and guidance. Harm reduction guidance in the hospital is less likely to come about with, all of the legal and safety concerns. But that's great. We can learn a lot from you. I don't know if anyone else had any other questions. This is really fantastic. I know we're looking for some clinical champions who can get this together for us. I think step one would be writing a pathway, and we could probably borrow some pathways from Marlene's work. And actually, I just learned that lots of area hospitals are doing this, including Lehigh Valley and Cooper. So it probably wouldn't be that hard to borrow from the local successes and also reach out to Marlene.
Happy to share any of the protocols, and I wish I also would love to hear about all the great work everyone is doing. And thank you so much for having me.
Yeah, it's fantastic. I think this would be where we would all meet and have a social hour, but not the downside is we can't do that, but the upside is you didn't have to fly across the country to visit with us. So this is fantastic that we were able to share in your expertise somewhat seamlessly from across the world. So really awesome to hear about your work, and definitely going to try and copy some of your models here.
Please go for it. And I'm sure I want to learn from what all the great work you're doing. We're about to implement extended release buprenorphine here, and hopefully now that it just got approved by the pharmacy committee, and I know you've been doing that for a while.
Yeah. Is it the Brixadi product or a different product?
Sublocade.
Yeah, I think our colleagues in primary care have done a lot of Sublocade. They can definitely share overcoming barriers and lots of opportunities for smoothing that path out a little bit. So thank you. I think there's a lot of thank yous in the chat. You should look and see how impactful you've been.
Thank you so much. Like I said, please feel free to reach out. I'm happy to share all of the protocols, and I'm going to go back and go see some patients with my team. Bye, everyone.
Awesome.
Have a lovely
day. Thank you.
Bye.
Thanks, everybody. We'll meet again in 2 months from today. And